Okay guys, today we're going to have a little discussion with one of our guest speakers, Jordan Arceneaux. He is one of the mid-level providers at Lafayette General Medical Center. He's a nurse practitioner that works with the general surgery and trauma teams. Jordan and I have been friends since we were teenagers. We were nurses together, we went to undergrad together, graduate school together, and we worked together as nurse practitioners together. So here he is. We owe him a big debt for coming to do this for us. Thank you, Jordan.
You're welcome. Thank you. I'm not going to walk around with this thing, but I will kind of go back and forth to it, I think. Okay, thanks. So we're going to kind of talk about surgical considerations for the biliary tree dysfunction. There's a lot of stuff that goes in there. We're going to talk about the right upper quadrant and the structures and the things that are in there. Again, James kind of said already, but my name's Jordan. I'm a family nurse practitioner. I went to UL. I finished a few years ago. Most of my background is in ER. A lot of trauma stuff as well. General surgery is kind of new to me, but it's fun. I've learned a lot. So just because I know y'all are kind of getting into clinicals, just to tell y'all a little bit about the group that I work with. You may hear us called a lot of different things. The surgical hospitalist is what we're commonly known as. The purpose of us, the reason Lafayette General brought our group in was because they were having trouble covering general surgery call. And so rather than trying to negotiate with a bunch of different surgeons, they asked our group to come in, form a group. We're here, we have 2 physicians around the clock that are on call, and then we have residents and mid-levels and lots of people. So we're an in-house service. We don't really have an office anywhere. We're hospital-based. So we're just like the medical hospitalist, but for anybody requiring surgeries, lines, any of those things. So, okay, you're going to see this picture or a similar one every slide because it's the most important thing. I think that when you're talking about, the biliary system, the most important thing to know is the anatomy. If you're not sure about the anatomy or if you kind of don't know what's going on, this is the picture you should really know. So just to kind of give you a quick again, we're in the right upper quadrant. Most of the things that we'll be talking about today is the gallbladder, simply because it's the most common. But some things we'll talk about is the liver in general. We'll talk about the pancreas. We'll talk about the duodenum, where it all drains. And then a little bit about the tubes that drain it all. But in general, what you should know, just kind of for a very, very basic start, is what happens is these structures all, for the most part, or for what we're dealing with today, produce digestive enzymes, digestive juices, those kinds of things. And so when you eat, your body makes these things. Some of them come from the liver, some from the pancreas. Some of the stuff from the liver is stored in the gallbladder until you need it. This is just a storage structure. It doesn't make anything on its own. And then all these things come down this tube we call the common bile duct into here. So again, starting way at the top, you have the left and right hepatic duct, extrahepatic bile duct. These things you don't really talk about all that much. They're not all that common. What you do here mostly is the cystic duct, so that's what connects the gallbladder to the common bile duct, which is the most common. And then you do have a pancreatic duct. Pancreatic injuries are very, very serious and they require lots of specialists, so pancreatic injuries are big deals. And then anyway, it all comes down. This is called the sphincter of Oddi. We'll talk about a little bit later. But all those tubes drain down here and drain their juices. So you can go to the next slide. Could you move this, please? Thank you. Okay, the first thing I want to talk about is cholelithiasis. By far, it's the most common call we get to the ER. I'm sorry, I'm still on call for like 10 minutes. I got to make sure. Okay, I apologize. By far, the most common call that we get is for cholelithiasis. And so all this is gallstones. This is just stones in the gallbladder itself. Come on in. You'll hear lots of different things. Some people will tell you that this is a completely asymptomatic problem, which it can be. You'll hear people say, well, gallstones don't cause pain. Maybe, but for some people it does. For some people it causes a lot of pain. A lot of right upper quadrant pain, epigastric pain, pain that radiates to the back. So don't let people tell you that gallstones don't cause pain. They can. But a lot of times we scan people for something else and we see gallstones and it doesn't hurt them. It doesn't cause any trouble. So why that is, we don't know. But for some people it's asymptomatic. For some people it's very, very painful. It's the most common cause of cholecystitis, which we'll talk about in a minute. But when we say cholelithiasis, specifically what we're talking about is stones inside the gallbladder. If they're somewhere else, we name them something different, but cholelithiasis is that. Usually when people come to the ER because of this, they're coming because of biliary colic. So that is just right upper quadrant pain. It usually comes and goes. It's usually associated with fatty foods. You can have a little bit of nausea or vomiting and some indigestion, but excuse me, typically when people come in, it's for this biliary colic. Murphy's sign, as you probably know, is when you push in that right upper quadrant really deep, you have them take a deep breath, and then when the liver or the gallbladder touches your hand, they kind of take in a breath.
That's you guys remember that from 209 Murphy's sign?
Murphy's. You should not see a Murphy's sign with cholelithiasis, because what Murphy's sign is trying to elicit is it's trying to see if there's swelling or inflammation of the wall of the gallbladder, which you don't have here. So you really shouldn't see a Murphy's sign with cholelithiasis. If the problem is simply stones in the gallbladder, everything else should be normal. The exam should be pretty benign, the vitals should be normal, labs are normal. If anything is off, that should start you thinking. We'll go to the next one. Again, this is anatomy. Like I said, I'll show this picture at least 10 or 15 times during the thing, but the most important thing to know is the anatomy. The next, the thing that I want to show you here is this is really exaggerated. This is probably 100 stones in there, I don't know. That's not really what you see, but this is kind of an exaggerated picture. And all these green things are different areas that the bile flows and that stones can occur. So again, we were talking about cholelithiasis, and that is stones in this structure here.
Does anybody have any questions so far? If you lost about something, now's the time to ask.
Yeah, you can ask at any point, you can stop me.
As we go. So right now he's just to make sure you know what we're talking about. He's talking about the gallbladder right here up in the liver, and he's talking about the drains. And you can see there's a drain from the gallbladder itself, and there's also drains that come up from the liver. He's going to explain to you why the symptoms can be different based on where these stones might be. Okay.
I do remember something that's not on these slides that I wanted to bring up, because it, as we're learning and going through things, we always see these pictures, and they're good illustrations, but they're illustrations. They're not how the body actually is. So if you were to look inside somebody, the gallbladder actually sits underneath and behind the liver. So if you did an exploratory laparotomy, if you open somebody up, the first thing you'd see right here is the liver. You'd have to peel the liver back to get to the gallbladder, just to give you an idea on what the structures look like. And they almost, the ducts that you're looking at really kind of go medial and posteriorly. It's deceiving to see it like this, because this is really kind of tucked up underneath the liver, but this is just an illustration. This is not exactly how it looks, but it's close. All right. All right, choledocholithiasis. I don't know why, I think it's a cool medical word, but you can go back.
Ooh.
Can I go back?
Let me,
Use the arrow.
Yeah.
Okay, so choledocholithiasis. So what we're talking about here is a stone in the common bile duct. Okay, big word, that's all it means. Stone in the common bile duct. So kind of keep this picture in your head. Remember, the common bile duct starts here, and it comes all the way down till it empties into the intestines. This is hepatic duct. This is for the liver. This is for the gallbladder, so it's cystic duct. This is for the pancreas. It's the pancreatic duct. Very easy. The one that they share is in common. It's the common bile duct. Easy. Hepatic duct, gallbladder duct, pancreatic duct. The one that they all share is common. Okay, can we go back? So cholelithiasis is a stone in the common bile duct. Remember I told you that cholelithiasis is a stone inside the gallbladder itself. If it's somewhere else, we call it something different. So when those stones come out of the gallbladder itself and move into that common bile duct, we call it cholelithiasis. Technically, these stones can form inside the common bile duct, but almost always they travel from the gallbladder. Sometimes you can see jaundice in this, and the reason is, as those liver enzymes and liver juices are trying to go out, the gallbladder stones, the gallstones are blocking it. And so that those liver enzymes back up and that can cause some jaundice. You know, so you can imagine if you have a tube this big and you have a stone this big, nothing can pass. And so things start backing up. And what causes that is that backup of fluid. Now you can also imagine you got a tube this big and you got a stone that's only this big. Things can still pass around. And so you may not always see elevated liver enzymes during a choledocholithiasis. So one thing that you should know is this problem, again, this is not an infectious process. This is an obstructive process. This is not something that's causing the wall to be thickened. It shouldn't need antibiotics. So if you see things like fever and white count, you need to kind of second guess if this is just choledocholithiasis.
Just to interject, what he just said was actually really important. You may want to write that down. Okay.
So I'll say it again. This is an obstructive process. It's not an infectious process. So if you see things that make you think fever, that think infection like fever and white count, kind of make your mind go somewhere else. This is just a stone that's obstructing a duct. If there's fever, consider something like cholangitis. We'll talk about that in a little while. Don't worry too much, but that's something you can consider if you see fever. The most important thing to know is that if there's choledocholithiasis, that patient needs to have their gallbladder out. And the reason is they're making stones. They either have more or they have the potential to make more. And what can happen is you can end up with a complete obstruction and really have a lot of trouble. So typically choledocholithiasis gets a gallbladder out during that visit. Not always, you know, sometimes we send them out and do it as an outpatient, but almost every time they get a gallbladder out. You can go back one more time. The thing that I kind of told you about, this is called the sphincter of Oddi. The reason, that's important for several reasons, but that's most commonly where we find choledocholithiasis. It's because it's the tightest area, right? This whole tube is pretty big, but then you get down to a sphincter that's tight. And so that stone moves all the way down and then it sits against that sphincter and it can't get out. So we most commonly see them here. And when I talk in a minute about the treatment, you'll understand why that's important, but that's where we typically see it. So another thing that's kind of important is you can see lots of different labs that get elevated here. We've probably got 5 people on our service right now, all with choledocholithiasis. It's really common. And it depends on where the stone is, how big it is, and where it's stuck. But you can see labs like the bilirubin, total, direct, indirect, alk phos. You can see a pancreatitis, and you can see cholangitis, which we'll talk about in a minute. Not so important for nursing, but just so you know, if you're looking at an ultrasound or a CT, and they say the common bile duct is bigger than about 7 or 8 centimeters, there's probably something in there. Even though they don't see it, the common bile duct shouldn't be that big. It should be 2 or 3 centimeters. 2 or 3 millimeters, like 0.2 centimeters, real small. This is treated with an ERCP, which I'm going to talk about later. Can you go back? I want to talk about one more thing real quick. Just so you kind of have an idea, again, not so important at this point, but I think it's good for your critical thinking. If you get a stone stuck here, you don't expect any elevation in your pancreatic enzymes because it's above it. These can still drain if the stone's here. If the stone's here, I expect elevations in the pancreas enzymes and the liver enzymes because it's blocking both. So a lot of times we use the lab values more than anything to tell us where is this stone stuck.
Do you understand what he's talking about? Mm-hmm. What are the pancreatic enzymes?
2 big ones.
They're ACEs, right? Amylase and lipase, right?
Mm-hmm.
And the liver enzymes he's talking about. Acetaminophen, statins, tequila, AST, and ALT, right?
Yep.
Alphos, all right.
So if it's up here, I expect, like he said, AST, ALT, alk phos. If it's down here, those plus amylase, lipase, potentially. You know, doctors spend a long time learning about this stuff. There's a lot more I could say, but I think that's a good basic knowledge about choledocholithiasis. You can figure a lot out just off of that. Yeah, again, I'll talk about the ERCP in a minute, so we can go to the next one. One more. This is just a thinking question, and I'll tell you the answer. Nobody has to answer it. Why don't we, so we being the surgery group, take this patient emergently or urgently to the operating room if they have choledocholithiasis. So if I get a call from the ER and they say it's choledocholithiasis, their labs are elevated, why don't we just go and take out their gallbladder? Something to think about. You can go to the next one. So there's three main reasons. The first reason is if we go in and take out that patient's gallbladder and the next day their numbers are even higher, well, is it that the stone is still just in the common bile duct, or did we injure something? Because when we're taking a gallbladder out, if we injure that common bile duct, we're going to expect to see a rise in all those same numbers. And so we can't get a clear picture on what's the problem. Is it an injured common bile duct, which is very serious, or is it just a stone still there? Not serious at all. So that's the first reason why we don't go straight away and take their gallbladder out. The second thing is when that stone is in that duct, everything's kind of inflamed and aggravated, and it makes it more difficult to get the procedure done. You have higher risk of complications. And the third thing is something we call IOC, and it's just where during a gallbladder removal, we shoot some dye into that common bile duct and look for a stone and try to clear it. So, if for whatever reason we have to take the patient for a gallbladder removal, IOC just kind of increases the risks. The thing that I want you to know from a nursing standpoint is that if you get a report from the OR and they say that your patient had IOC in the procedure, you should just know that that's a little something extra. We have to actually enter their common bile duct or their cystic duct to be able to complete the procedure. They're just at a little higher risk. We put needles in there, we shot dye. So if you hear that your patient had IOC, just kind of be thinking about that. So what the surgeons prefer is that we do an ERCP first, which again I'm going to talk about. But that's a procedure that's done by the gastroenterologist. I like the anatomy. Keep going on. So this is probably oh, don't you want to say something?
Oh no, this is what you are focusing on a lot in class right now, okay? Is the difference between cholelithiasis, which is just stones, not an infection, and cholecystitis, which is an infection of the gallbladder, okay? So you might have heard some of this before already, basically.
So cystitis, you should always be thinking about an inflammatory process. There's cystitis all over the body, but cholecystitis isn't specifically what we mean is an inflammation of the gallbladder wall. It's infectious, and about 90% of the time it's due to a stone that's irritated and caused an infection. Now this is when you see fever, right upper quadrant pain, nausea, vomiting, Murphy sign, that referred pain to the shoulder, all the stuff it says in the book. That's when you see all this stuff, acute cholecystitis. This is infectious, this requires antibiotics. Lots of ways to diagnose it. Most commonly people get CAT scans or ultrasounds. We prefer ultrasounds. They're much more specific for this problem, and also they are cheaper and they do not expose the patient to radiation. So ultrasound is our test of choice for this. It's very good. You can do a HIDA, an ERCP, an MRCP. We'll talk about some of these, but you may see some of these letters as ways that we kind of help differentiate. Is it cholecystitis, cholelithiasis, none of the above, choledoco? That's what we're kind of trying to reason. So with patients with cholecystitis, they need to be NPO. The first reason is they're going to surgery. So everybody who potentially is going to surgery should not be eating or drinking. If you're on the fence, don't eat or drink. Nobody will die from a day or two. They think they're going to die. Nobody's going to die from a day or two of not eating. The second reason is that gallbladder is very distended and irritated. As you eat or drink, the gallbladder wants to contract to put out digestive enzymes. It doesn't know what you're eating. And so as you do that, you're worsening that inflammation, you're worsening the patient's pain. So that's the second reason. Again, these patients need antibiotic. This is an infectious process, and it's painful. We give them pain medicine. Just so you know, there is some evidence in the literature that these patients can be treated as an outpatient with just Cipro and Flagyl, but the return rate of patients who need to have their gallbladder out is over 50%. And so we don't typically do that, but that is an option. Laparoscopic cholecystectomy is the standard of care. We're going to talk about that procedure in a minute, but you'll hear it called laparoscopic cholecystectomy. The last option for treatment is what we call a cholecystostomy tube or C-tube. We'll talk about that in a minute, but that's a last ditch bad option, but we do them here all the time. I don't know, is this something that's like in their literature or that they know?
You can run through it. This is supposed to be supplemental anyway.
Yeah, so this is very true. I mean, we see gallbladder dysfunction in young people, we see it in old people, but I'll tell you that classically, we see it in the 6 Fs. Women who are still of childbearing age, who tend to have a lot of gas, who are in their 40s, who are a little bit fluffy, and whose mama had their gallbladder out. This is the picture that you typically see. You can kind of make that picture in your head. Female, fertile, flatulent, 40, fluffy, and family. If you get a call or if you see a patient and they're in the ER and they look like this.
We used to have this little inside joke between the ER nurses every time someone would come in looking like this, and we would say, looks like every other gallbladder I've ever seen in my life, type thing. They would always hit this profile.
And it is. I mean, it's really, it's unusual, but this is a good way to kind of think about the type of patients you should see with gallbladder dysfunction. You know, one more. This is a less common problem. This is 10% of our cholecystitis. So this is when we go and look either with any of the tests that we use and we find a cholecystitis, but we can't find any stones. This is usually a bad sign. We typically see this more in very, very sick, like critically ill patients. A lot of times, patients in the ICU end up getting diagnosed with this. You know, they're admitted, they look septic, nobody knows what's going on, they do all these tests, and then it's acalculous cholecystitis.
So like A without calculus,
Stones, no stones. I wouldn't think much about this. But again, this is in critically ill patients. So you need to, sepsis without a cause, you need to always have acalculous cholecystitis in the back of your head. A lot of times, unfortunately, acalculous cholecystitis is associated with a gallbladder cancer. So it's kind of bad news. But these are sick patients. Your typical patient on the floor with cholecystitis has stones. You can almost bet it. So this is a life-threatening condition. This is cholangitis. This is not really something that the surgery group that I work for handles, but it's something that's involved in the biliary tract. It's something we get called about, and it's very, very serious. So 88% of people who, if you don't treat this appropriately, will die. I mean, that's an incredible mortality rate. I don't know any, I mean, there's not many things that have that mortality rate, so that's high. The things you'll see in the book, and actually these are real, these two things kind of go together. So they have what they call a Charcot's triad. That's, if you see a patient with jaundice, fever, and right upper quadrant pain, bad news. If you get those, plus they're hypotensive and confused, they're close to dead. I guess you could do it from there. So usually what happens is, can you go back one? What we're talking about with cholangitis is essentially an infection of the tube. Okay, the tube itself gets infected. And the way that that happens is, you know, we all have bacteria in our intestines. That bacteria begins to move up the tube. So it's an ascending infection that comes this way. It's very difficult to treat, and for whatever reason, the people who get it are already very weak and sick, and that's probably why they get it. You go to the next one. These are almost always your ICU patients, and the only thing you really do is the only thing that you'll see done at a hospital like this is IV antibiotics. At some places, primarily teaching hospitals, some kind of big academic centers, they're trying different things to see if there's a surgical option to repair this, because surgeons love to cut things out, and so they're trying to cut stuff out. But really the literature at this point says surgery is not a good option. The option is IV antibiotics, hydration, good general care. Again, I keep using this. I probably should move ERCP up to the beginning of the presentation because it's very important, but you can do an ERCP or you can do an IR drainage to kind of help relieve some of the symptoms and backup that causes this.
So just as a recap, this is an infection of the biliary tree.
Right.
So all those tubes he was showing you, this is what happened. This cholangitis is when those tubes get infected.
Not so much, it's not an infection of the gallbladder, the pancreas, the liver. It's the biliary tree that gets infected. You can't take that out. I mean, it's impossible, really. And so that's why the mortality is kind of high, because your only option is antibiotics, and usually by the time you find cholangitis, the patient's in ICU on pressors, and there's not much that can be done. Okay, so the most common procedure that we do as a service, we do on average 2 a day, 365 days a year. We do almost 1,000 of these a year at this hospital. That's just the group I work for. There's a few more that other people do. Very common procedure. If you're a nurse, it doesn't matter. I don't know, I guess unless you're in the NICU, you're gonna take care of a patient with a lab coat. So some things that kind of from a nursing aspect that you need to be thinking about preoperatively. These are the things we want you to be thinking about preoperatively. First of all, is the patient on Coumadin or Xarelto or whatever? If so, they'll need cardiac clearance. Most commonly, we can bridge them with heparin, but it kind of all depends. Sometimes we'll just let them trim down, do the surgery, and pick them back up. The other thing you need to consider is how many abdominal surgeries have they had. If they've had 10 abdominal surgeries, they might not get a laparoscopic surgery because by the time we get in there, there's going to be so much scar tissue we can't see. They may end up with an exploratory surgery, which is open. But that's something that you need to consider. Do they have allergies to certain medications? What are the anesthesia risks? And then the other thing you should always be thinking about on a patient going to the operating room, I mean, this is a big deal. Is there something else? Or did we miss something? You know, is there something else that could be causing this problem? So that's all things to think about. Once we get into the operating room, this is just general kind of things to think about. So every surgeon has a preference. You know, everybody holds their pencil different. Everybody places their ports differently. You're never gonna, I mean, even the same surgeon will place ports differently based on what he sees when he gets in. They'll put a port in and they'll first thing they put is a camera. Based on what they see, they'll move their ports around. Almost everybody puts a port right in the belly button and then kind of goes from there, but you never really know. You'll typically end up with 4 ports. You may get 3, you may get 5, but they're all different. So
What he's talking about with the ports, it's just a little plastic hole that they'll put in the skin so they can introduce a camera rod to go in and out of it. That's what he's talking about with the port.
very small. Those we close up and we sew from the inside. The patient has stitches, but they won't know they have stitches, or it's not something that needs to come out. They'll never see those, but we sew those up from the inside. So for various reasons, often the gallbladder will kind of spill out. If there's not a bunch of infection, we can continue a laparoscopic procedure, wash it out, suck it out, the patient's fine. If the gallbladder is full of pus, we may convert to an open. So it started out with just the cameras laparoscopic, but then we had to convert to open. So you may find, you may send your patient for a lap chole and they come back with an incision this big. We had some kind of issue. Typically the gallbladder spilled out and it was full of pus. You will see, we place 3 staples. Can you go back one slide? So the 3 staples that we place are on the cystic duct. Make sure I'm not right. On the cystic duct. Now you got to remember that there's veins, arteries, all kind of stuff going back and forth that we have to work through. But the most important part of the procedure is the 3 staples. So we place 1, 2, 3, and we leave 2 in the patient because the biggest thing that we don't want is bile leak. Think about why bile leak would be bad. Bile is what digests fats, primarily. Your abdomen is full of fats. That bile will start to digest, essentially digest your insides. Bad deal. So it's very important that this connection is sealed. So we put 2 staples, leave that in the patient. We put 1 staple on this side and we cut here. So 2 staples here, 1 here, cut in the middle. And then we take this out. So, if you ever see an x-ray or a CAT scan or something and you see 2 staples in a patient in that area, they had a gallbladder. All right, you can go forward 1. Okay, IOC. So, I'm sorry, back 1 more. I keep going back and forth. That's why I put so many of these. So what IOC is if we think there's a stone here or here, we'll put a needle in right here, shoot some dye down, and it's diagnostic and therapeutic. So it's diagnostic. What we do is we shoot some dye and take an x-ray. If we see what looks like a stone, we know it's there, but it's also therapeutic because the pressure from the IOC can flush that stone out and cure it. And then you shoot another one and make sure it's cleared. I mean, it's not 100%, there's nothing 100%, but that's a good way to diagnose if there's a stone there. But again, you're inserting a needle into the abdomen, into a super tiny little structure. and hoping for the best. So it's not the optimal way to do it, but again, we do these all the time. All right. The most common complication in a laparoscopic cholecystectomy, every surgeon's nightmare, is damage to the common bile duct, because bile will leak out and you'll have to go back in there and repair it, and that's very, very difficult, and it has high morbidity and mortality. So common bile duct injury is very serious. So post-operatively, again, it depends on the indication. You know, you can do this for cholelithiasis, cholecystitis, resolving choledocholithiasis, but unless there's a pretty bad infectious process, that patient can often go home the same day because you've taken out the problem, whether it's stones or infection, you've taken out the source. Those patients don't usually need antibiotics after.
Y'all are gonna get asked that question all the time by family members because it's so common. Hey, they told me I have to get my gallbladder taken out. When do you think I'll be able to go home?
If we do it early in the morning, they can often go that afternoon. Anytime after about noonish, it's just kind of pushing it for the same day, so we let them go the next day. But that's the expectation. After the surgery, the patient doesn't have any specific requirements for diet from a surgery standpoint. We start them on clear liquid diet, not for surgery, but because anesthesia gave them so much drugs, they're gonna puke if they eat. It's really nothing to do with us. They could eat a hamburger if they wanted. But some people, not everybody, have fat intolerance for different periods of time. So people go eat a piece of boudin cracklings. That may cause some nausea for some people because their body is still learning how to produce bile. It used to have this big bag that would help it. Now it doesn't have it. So not everybody gets that. Some people eat boudin and do fine. But some people for a few weeks or a few months have that problem. You should always try to get a good report from the OR nurses. The OR nurses know if it was complicated, uncomplicated, did we have trouble, did we tear something, did it spill? Try to get a good report and that'll help you know. Probably the single most important thing is getting these patients up. They just need to ambulate. They need to get up, they need to not have IV pain medicines, and they need to try to start eating and drinking. Once they can do that, they can go. They don't need to have a bowel movement. We didn't touch their intestines. There's no reason why that's an issue. Now, voiding is an issue. Urinating is an issue because they had a Foley. But, so they need to void. They don't necessarily need to have a bowel movement. We often like them to. That's just because that's what we like to do. There's no good evidence for that.
He just likes good food.
Surgeons love food. I don't. Yeah, it's one of those, it's terrible because we shouldn't do it, but it's one of those, we've always done it that way. So there's no good evidence for it though. And once you have your gallbladder out, things should get better and better. If they're not, if you're getting a new fever, a new lab value that's elevated, something is off. There may be a new infection, you may have injured the common bile duct, maybe you left a stone in there that you didn't realize, but you should get better, not worse. I mean, you're gonna have some pain, maybe a little more the next morning, but you shouldn't see changing labs or vital signs. Post-op nausea is normal. Again, it's anesthesia's fault. Don't blame it on surgery, blame it on the anesthesia people. The other thing is, and this is kind of excessive, every surgeon's a little different on what they want, but no lifting over 10 pounds, which is a good point. In surgery, when we say heavy lifting, in general, we're talking about 10 pounds. That's about a gallon of milk, so you can tell people about 1 gallon of milk for 4 to 6 weeks. The main reason we tell you that is you could develop a hernia at the laparoscopic sites. It's very, very low risk, but I'll try not to get too far ahead, but if you just think basically you have your skin on the top and the fascia, which is the muscle underneath. In a laparoscopic surgery, we don't repair the fascia in our typical incisions. We repair the skin. So technically they still have a small defect or hole in the muscle layer. And so if they do too much heavy lifting, the intestines could come through that muscle layer and cause a hernia. It's low risk because we're talking about an incision this small, but we tell people at least 4 weeks no lifting over 10 pounds. This is really the only restriction we have. People can walk, run, ride a bike, swim, whatever they want to do. No lifting for 4 to 6 weeks for that. So this is a cholecystostomy tube. If you have spent...
I don't want to interrupt you, but this little thing he's about to go into right now, you would not believe how many nurses go 10, 15 years in their career, I was one of them, without knowing exactly what this is. and he's about to give you a detailed explanation on it. So tell your friends, tell your wife, you know what I mean, this is what it is, okay?
This is something that we do a few of a year. We have had 3 that I can think of pretty quickly in the last 6 months. This is for a patient who, for whatever reason, cannot have a lap chole. So it may be preference, although that's not common. The main reason you see this is the patient is not well enough to undergo a procedure. A procedure will kill them. And so we do this as a temporizing measure, something that can give them temporary relief. This is something that's done in interventional radiology under CAT scan guidance, ultrasound, typically CAT scan. There's a couple of different approaches, but typically they have to go through the liver, so that's a little high risk, but they go through the liver and put a drain into the gallbladder. We connect it to some kind of suction, typically the bulb suction, and we irrigate, we drain out the gallbladder. We take the infection out. So again, these people are typically very sick. They're typically in the ICU. They're too sick to undergo surgery. These are typically people with acalculous cholecystitis. Those people will have this, and it can stay in for a week, 6 weeks, 6 months, 6 years. We never know. It just depends on, we leave it in until the patient's well enough to have it out, and it's not draining anymore. Sometimes, and I won't get into too much detail of this, but sometimes after we pull it, we have to go back and take the gallbladder off. Sometimes no. It depends on if it's calculus or acalculous, but that kind of doesn't matter here. The thing you need to know is a cholecystostomy tube is used to drain the gallbladder in patients who are too sick. It's placed by interventional radiology, and it can stay in forever. I'll tell you that of the 5 or 6 or 8 or 10, I don't know how many I've seen, nobody has survived to discharge. That's kind of anecdotal, but typically if a patient's too sick and they need this, they're not going to make it. But you got to do something, and it's a chance, and it's better than doing absolutely nothing. So some people do survive, but typically these are ICU patients who don't do well. That's what all that says, but let me just make sure I said it all. Yeah, I think I said all that. All right, gallstone pancreatitis. Can you go back one? So again, gallstone, that's all these, but they've moved out, and what they can actually do is reflux or go back into the pancreas. So you get a stone that'll get stuck here. Even a choledocholithiasis can cause gallstone pancreatitis because it's blocking it up. So that's the structure, that's where we're talking about. The most important thing about gallstone pancreatitis is strict NPO, because the pancreas is very, very sensitive, and when you eat or drink, it produces a lot of digestive juices. And that pancreas will get more and more inflamed, and you'll cause a lot of problems if a patient tries to eat or drink with gallstone pancreatitis. Sometimes we do NG2, that's what NGT is, NG2, because we don't even want their gastric secretions going down and stimulating the pancreas. We want absolute bowel rest. These patients 100% have to have a cholecystectomy on the same visit. Not on the day of admission, but on the same visit. Excuse me. And the reason for that is you can develop all kind of pancreatitis, which is serious. You can develop pancreatic pseudocysts. You can develop, necrotizing infections, all kinds of things from gallstone pancreatitis. Gallstone pancreatitis in and of itself is not a very serious thing, but you have to take care of it and treat it. Again, ERCP, we'll talk about it in a minute. But sometimes this can lead to cholangitis because those pancreatic enzymes are very, very irritating. You irritate that lining, that's kind of a nidus or an area for infection to come in. So sometimes with gallstone pancreatitis you can see cholangitis, but not always. But that's what the book will tell you. All right, anybody seen a picture like this?
Who can guess what all that, what you're looking at?
Is that the duck?
Yeah. I'm gonna turn the light off just for 1 second, just so we can see this picture. All right, this is an MRCP. MRCP is a test that we do in the MRI area, and we are looking for structures primarily. So they're never this good. This is from a textbook, They're never this good. but this is a good one. So this is the gallbladder. You can see it lit up. Inside the gallbladder, you see increased densities. That's stones. This is the cystic duct. The cystic duct is not like a nice straight thing. It's tortuous. I'm from Character. Anybody from Character? No?
Upper Lafayette.
Upper Lafayette? I can't say torturous because I'm from Character, but this is a very torturous tube. And it just, it just kind of curves and makes all kind of different shapes. That's why it looks like this, but this is the cystic duct. And then you got common duct. And because this is a really nice fancy one, you can see the pancreatic duct here. This is the duodenum. Left and right hepatic ducts. So just so you have an idea. So this will tell us, big problem, this is the sphincter of Oddi. So you got a bunch of stones in the sphincter of Oddi. You got stones in the gallbladder. If the radiologist can sometimes off of these talk about the lining, but that's rare. What you're really looking for in an MRCP is the common bile duct and this looking for stones. You go to the next one. The alternative to an MRCP, so MR is magnetic resonance, it's an MRI test. The alternative is an ERCP. That's something that's done by the gastroenterologist. They come in through the patient's mouth, through their stomach, through the first part of the duodenum, through the sphincter of Oddi, and then they can do all kinds of stuff. So they
Just
can.
take a minute to appreciate like how complex that is.
It's very complex, and you'll hear surgeons and urologists and GI doctors say technically difficult. They don't mean technically like we all say technically. They mean that it's hard to do it. It's hard to get your things in the place you need. This is a very technically difficult maneuver.
Yeah, y'all freak out about an IV. It's really hard to do.
And they're not all created equal. Some are much better than others, just like all of us, But
it's not staying still either. All this stuff is moving, right? Your intestine.
the patient's on their stomach, which that's
Breathing.
based on anatomy, but it's very difficult. It's not like we'll just get an ERCP and do it. They can do a lot of things in an ERCP. The first thing is they've got to be able to get into the sphincter Oddi. If they can get in, they can shoot some dye so that they can see. They can do what they call a sphincterotomy, where they kind of open that sphincter of Oddi so things can drain. Depending on why you're doing it, we're talking about it for gallbladder dysfunction, but for instance, our trauma patients who have an injury to their pancreas, they can try to come in and put a stent. So an ERCP is used for lots of different things. If the surgeons mess up, if the doctors I work with injure the common bile duct, we call and beg and plead the GI doctors to come and stent across our mistake. So if you have a little cut here that we nicked, we ask them to come in and put a stent so that it can't leak out. So there's lots of things that can be done in an ERCP. But typically when you're talking about gallstones or choledocholithiasis, what we're asking them to do is come in and do a sphincterotomy and tell us if they're stones. And they can tell you. So usually they'll say, yes, they were stones and we got them out. No, there weren't stones, or there are stones and they're still there. I can't get them. You'll have to do an IOC and shoot from the top. That's an ERCP. You go to the next slide. So I kind of have like a contrasting thing. So MRCP, again, that's an MRI test. It's done by radiology. It's only diagnostic. An MRCP will not fix it. It's much cheaper. It's quick. There's really no complications, and it's very reliable. I don't like to talk about other specialties, but GI doctors love to do this first because they can just press a button on a computer and it gets done, and then they can see what they want to do. We want them to do this because often what happens is they do this test and then it's positive, and then the next day they schedule them for this, and then the next day we can take out their gallbladder. Whereas if they do this the first day, the next day we take out the gallbladder. It's sort of just a process thing, but the reason they do that, they have a good reason, is this requires anesthesia, it requires a tube in your throat, it requires them to go through the sphincter of Oddi, which is dangerous, and so that's why they do it. But So this is endoscopic. It's typically done in the GI lab. It's diagnostic and therapeutic, so they can clear that duct in an ERCP. Again, if we have a common bile duct leak because we messed up, they can put a stent. Very, very reliable. One of the last tests is a HIDA scan. This is a nuclear medicine study. The big thing for nurses is you cannot give dilaudid or morphine for 6 to 8 hours. That causes that sphincter to contract. And so they can't get a good test. But this is basically checking, you'll get an ejection fraction. They'll tell you how much of that stuff is leaving the gallbladder. Usually we use this if the picture is not clear. But what it does is it causes, they drink some stuff and it causes the gallbladder to contract. Usually if they drink that and they have pain, it's positive. That's a positive. But this can also see the gallbladder wall. So that's in about a HIDA. You'll see them from time to time. It's just one of our tools. This is rare. I have never seen this, but it's in all the literature. It's in all the books. This, anybody know what this is?
What'd you say?
Anybody know what this is? A picture of? I mean, it's like a cheap picture. It's gallstone, a gallstone ileus.
Yeah, that's the ascending colon right there on the left.
Yeah, so it's right here at the ileocecal junction. So this is the bottom of the small intestine, the first part of the colon, the ascending colon. Your appendix would be somewhere here. What happens is a gallstone breaks free from the gallbladder and gets into the intestines and makes it all the way down. Same thing, it's at a sphincter. Usually when you have an obstruction, it's at a sphincter because that's a tight area. The weird thing is these are caused by connections between the gallbladder and the intestines. Because a stone that's big enough to do this is never going to make it out the common duct. It's going to get stuck and we'll take it out or something. These are when you have these massive stones in the gallbladder. It causes a fistula, a connection between the gallbladder and the intestine. And then you'll get this huge gallstone that'll come out. It'll make its way all the way down the intestines with no problem and get stuck. You go to the next slide, please. So they're very rare. Like I said, I've never seen one, but it's always something we think about and talk about. It's hard to diagnose, so it's got high morbidity and mortality. It's usually from that fistula, that connection between the gallbladder and the intestines, not the common bile duct. You gotta go in and take the stone out some kind of way. We do an ileocectomy. It's not important, but we take out that part of the intestine. And then you always, it says often, you always take out the gallbladder so it doesn't happen again. That's kind of it about the gallbladder. I'll say a few things about the pancreas just because we're talking about that whole system. Pancreatic pseudocysts are not a true cyst. So a true cyst it has an epithelial lining and it's got fluid in it. What a pancreatic pseudocyst is, if you think about the pancreas and it would have just a lining, it's fluid in between its real lining and the pancreas itself. So it's not really a cyst, but we call it a pseudocyst. Pseudo's like fake cyst. So fortunately, 75% of pancreatic masses are this. 25% are cancer. Everybody knows pancreatic cancer, bad news. So 75% of the time you see something sitting on the outside of the pancreas, it's a pseudocyst. Usually you see this in chronic alcoholics. As they get pancreatitis over and over and over again, their body kind of walls off and makes this pocket of fluid. It can be full of blood, which is we see typically in trauma. Those are bad. Those end up having to get transferred for a procedure we call a trauma Whipple. Very, very complex. It can be full of pancreatic enzymes. Most typically it's full of necrotic tissue, just that pancreatitis kills the pancreas as it goes because it's digestive juices. And so that dead stuff sits in that pseudocyst. That's what we most commonly see. These things are very slow forming. They take about 6 weeks to form. We do drain them. Either interventional radiology can drain them or surgically we can drain them. But most times they drain on their own. It's not an emergency. What you usually do is you get serial images, either ultrasounds or CAT scans over the course of time. And as long as it doesn't look infected, you can watch it. And what you really want is for it to form a nice rind, like a rind like on an orange, so that it's easy to get into. But again, most of these resolve on their own. We don't rush in to take them out. We kind of watch them over time and take them out. Just a couple of pearls and pitfalls, just some things.
For y'all, this big this pointer right here.
Some things I think y'all should know from a surgery standpoint. Lovenox. Probably one of the most life-saving drugs that ever was made, truly. We've prevented more DVTs and PEs in patients because of Lovenox than anything else, I think. This says most, but I can tell you every one of the surgeons that work for the service that I work for, the doctors that I work for, do not, absolutely do not, no matter what, want you to hold a Lovenox. We can stop bleeding. We cannot fix a PE. We can always stop bleeding. So it doesn't matter for us if we're amputating a leg, taking out a gallbladder, I don't care what we're doing, don't hold a Lovenox. If you're not comfortable or sure, call us. That's why we have people on call, even if they're grouchy. Call them, ask them about the Lovenox. Now, this is not true for every specialty. Don't give your neurosurgery and whatever other patients Lovenox. Check with them. I'm just telling you for the general surgeons that I work for, we give Lovenox. And most of the specialties, orthopedics wants it. Neurosurgery, probably not so much, but a lot of doctors now, especially general surgeons, want that given. Surgical patients are probably your highest risk for some kind of thromboembolism, DVT or PE primarily.
If you think about that triad y'all learned about recently, is there an injury to the endothelium? Yeah. Is there venous stasis? Yes. That's why they're at such a high risk.
Yep, high risk. Forget about the amount of patients who die from it. The hospital won't get reimbursed for your problems if they have DVT. So
just for the money's standpoint, it's a good idea.
You gotta get paid to have a job. Lipase and amylase, we touched on those. Lipase is a lot more specific than amylase, but again, just because it's the way we've always done it, we order both. Amylase will go away a lot faster. So if you see a normal amylase and a high lipase, you can kind of assume that the problem is getting better. You don't know that for sure, but typically we get lipase. And a little bit of an elevated amylase and lipase is okay. That can be from a number of things. But if you see 2 or 3 times the normal limits, they have pancreatitis. And again, it may be gallstone pancreatitis, alcoholic pancreatitis, it may be traumatic pancreatitis, it could be anything, but we use the number of about 3 times the normal pancreas levels, amylase and lipase, to determine pancreatitis. Just in surgery in general, I'm sorry. In surgery in general, we send pathology. It's our responsibility to check that. So it doesn't matter what we take out of somebody, we send that to check for cancer. It is the surgeons and the nurse practitioner's jobs to check, but it's part of a team. You should be looking for the surgical pathology report for any of your surgery patients, just to make sure that doesn't fall through the crack, because sometimes it does. Again, we take out cancerous gallbladders and appendix all the time, so keep an eye out for that, and those are very serious. Just for an idea of antibiotic choice, Zosyn is our antibiotic of choice. It does have penicillin, so if they have penicillin allergy, they shouldn't be on Zosyn. For things that are intra-abdominal, we use ciproflagyl or meropenem if they're allergic to penicillin. So those are some things you should see. The last thing, kind of just in general, not necessarily about this, but just nursing in general, I think this is kind of one of the best things somebody told me when I was kind of starting out as a new nurse. You know, labs are good, tests are good, all these things are good, but your physical exam and your critical thinking are what's going to save you and save your patients. It doesn't matter what the labs say, what the CT says. If it doesn't look right when you put your hands on the patient and when you think about what the problem is, use your critical thinking and your physical exam first, and then let the rest of it guide you. I worked with some great ER doctors who would not look at a chart until they would see a patient. They didn't want to be biased by the labs, what the nurses told them, any of that stuff. They want to go in, do their exam, and make their own assessment, and then use the labs to back them up to make the diagnosis. And we should do the same things. We should go in there, touch our patients, put the stethoscopes on them, and make our decisions from there. So that's basically all I have. I know time's kind of getting really close, but if y'all have any questions.
Just to back up on the history, I mean, how many times have you guys said, I'm not really sure what's going on with my patient, and I'll say, what? Come over here, let's look at the H&P, let's look at the notes. And how much information do we get out of all that H&P and the notes? So the history is super important.
Yeah, it really is important. And I mean, history and physical exam truly, you can't overstate it. So,
And for my group, we are staying till 3:15. So if you think by not asking questions you're gonna catch the 3 o'clock bus, obviously Miss Kizar, y'all go whenever. But this is a very rare opportunity to get someone like Jordan to come talk to us. And while you're gonna have good relationships with docs and NPs when you get out as nurses, you rarely get an opportunity to ask whatever you want without being embarrassed. So now's a good time.
I can tell you one or two things if I had another minute. Has anybody, whoever has to go, have a good life, see you later. Try not to kill anybody. Has anybody done, we got a really interesting, thank y'all, I appreciate it.
Thanks, Vinny.
Has anybody done do y'all don't go to the ICU, huh?
In their senior year, they do.
Have a senior.
Senior semester, graduating semester.
We have a very interesting pancreas case that we've had for a while. Just to kind of briefly tell you what happened, this is she's actually she works in a hospital. So what happened to this person is she was in a car wreck, and I'm trying to get to the best picture I can. She was in a car wreck, and it was a very, very bad car wreck, high rate of speed. She had lots and lots and lots of other injuries. But actually the thing that is doing her the most damage is she has a pancreatic injury right at the flexure, right where you see how it kind of goes up and then makes a turn, right here. The problem is the way that the blood vessels and things go into it, this part has to be taken off, but she has to have a complete resection of all of these structures. Every blood vessel has to be reattached, something that's only done in just a few centers in the US, big, big places. It's called a Whipple. I mentioned it earlier. We do some Whipples here, but this is called a trauma Whipple because it's involving a trauma.
And
So-
a Whipple has a life expectancy of about, what is it now, 6 months, or they've been able to bump it up?
Well, you know, like the doctors here, y'all may see cases from Dr. Jason Breaux and Dr. Some of his partners. They do some Whipples that are much more controlled, and they do well. They typically do Whipples for cancers, but what they're trying to do is, what they're doing is taking the head of the pancreas off. They're reconnecting the pancreas back to the intestines, back to the gallbladder, back to the liver, back to the stomach. Big, big, big surgeries. So just for an idea on the type of things that are happening.
And Dominic, you had a question?
No, I was just gonna say, the Whipple only gives you like a certain month. It's pretty much just giving
For
you.
cancerous, yeah, the surgeries they do Whipples for cancer, yeah, that's typically like okay, we're gonna do this and this is it. So
Dang.
go skydiving and
For
Rocky
another
Mountain
6
climbing
months.
and all
That's
that
tough.
other
There's a
kind
country
of
song
stuff.
about that. Yeah.
So they take it off and then put it back?
Right, because they're taking off this part, and actually this picture you can see it better. It's actually much more complex because they disconnect the blood supply that feeds this, also feeds the first part of the duodenum and some other structures. So they actually have to take the duodenum off. They reconnect the duodenum up here. They have to make a new connection for all three of these back into the intestine. Incredibly, I mean, it's like,
And they have to be 100% leak proof.
it's probably the most complex procedure you could imagine. We do them here, but it's a very complex deal. We have some great surgeons here who do those. Those are pancreatic specialists. So just kind of for an idea on other pancreatic injuries you may see. And y'all are on 10th floor. The other group, what floor y'all on? Yeah. Okay.
You can hit stop on the phone and